So we will be starting with an overview of the GRADE approach and process. I thought by starting with presenting you a definition of what a guideline is or a recommendation is, and that's a WHO definition, but I think it fits very well, and it deviates from what the IOM has used as a definition for recommendations or guidelines, which is not a problem in my view, because the main difference is that here we are focusing on recommendations in any type of context rather than the clinical context. So guidelines are recommendations intended to assist providers and recipients of healthcare and other stakeholders to make informed decisions. Recommendations may relate to clinical interventions, public health activities, or government policies. So main difference, if you look at the IOM definition that I'm not putting up here, that was recently put forward in the IOM report. The IOM report focuses on clinicians. And I think guidelines go much beyond the individual patient care, obviously. For those of you who are interested, a few years ago we were asked by WHO to review the development of the development processes for guidelines, and we covered in a 16-article series topics from guidelines for guidelines down to evaluation of guidelines, with really all of the topics that are relevant in our view for guideline development. Covered in individual articles in this series that was published in a BMC article. It's about 5 years old. Obviously there have been developments, but for some of the background material this is helpful reading. Okay. What we put great emphasis on in these organizations, large organizations that develop guidelines, are basically 4 main points. One is once you developed your question, you should obviously make sure that you search for and retrieve all available evidence that is relevant for your question. In many instances, you can actually work with existing systematic reviews if they are done in a way that they permit you to answer the question that you have at hand. Sometimes you need to identify systematic reviews and perhaps do extra work, either update the systematic review or address outcomes that were not necessarily included in the published literature. So sometimes you can use existing systematic reviews, sometimes you use them and update them or use part of the information. It should be accompanied by a formal assessment of your confidence in the estimates of effect or quality of evidence. And then the way that many organizations are doing is they use this approach, the GRADE approach. And the reason why I have this slide here is to remind you that GRADE really is not necessarily telling you how to do these steps, either to do the systematic review or searching the literature, formulating the questions, but we provide a lot of guidance. In other words, whatever you do in this approach does not influence the type of work or the amount of work or the resources that you need for doing this. However, in fact, we believe that this approach actually helps you to streamline work, and it makes these first 2 steps much more efficient. By identifying, as I said, questions appropriately and focusing on the relevant outcomes. And this will become more clear as I continue to present to you. Then, as I said, we use GRADE then for assessing the evidence and moving to recommendations.
Holger, do you want us to ask questions as we go?
Yes, please.
I've got 2 questions. One deals with unpublished data. Where do you rank unpublished data into what you just said? And secondly is, there are other groups that are doing reviews. In our particular case, SAGE is doing reviews that we're doing. And how should we depend on what's already been done? Should we take it wholeheartedly, or what should we do with that information? So those are 2 questions.
Yeah, both excellent questions. So unpublished data, as part of the systematic review process, I think you need as a group to decide whether you are going to use unpublished data, obviously, as the first step. Our take on this is, as long as you can gather the information from the unpublished data that you need in order to do this assessment. In other words, you can get not only the number of events and the patients and the number of people involved in the study, but you can also get the information that you need for the quality assessment, So for instance, was it randomized? Was it concealed, if it's a randomized controlled trial? Or in an observational study, was follow-up complete? As long as you can get all of this information, I don't think there's anything that precludes you from including unpublished data. So it should be done. It avoids publication bias. It avoids other biases. And in regards to relying on other groups' work, I think collaboration is extremely important. You can go out and assess how the systematic reviews that, for instance, SAGE were done. There are tools out there to do that. The AGREE tool, for instance, is one of the tools that are frequently used to assess the quality of a guideline development process, and that so if SAGE has developed a guideline, it should also help you with assessing whether the systematic review was actually done, whether the outcomes were assessed appropriately, and then you could take either the guideline and adapt the guideline, or use the systematic reviews. There's obviously the MSTAR tool to assess the quality of a systematic review. This is just being updated actually, and will become much more helpful. So you can use these tools to assess whether you can trust the systematic reviews that are out there. But in the most instances, if they are done well, I would use them, update them as appropriate, and include information for the outcomes that you need. Yes?
Any advice on how you can be systematic in your literature search and include unpublished data? For example, whenever you're really rigid about documenting the search criteria, search strategy, and all that, it seems hard to incorporate unpublished data.
I mean, a quick answer is that so what we do with many of our reviews where we look at the gray literature, it is screening the relevant conference proceedings, obviously, if you consider that. But for the most part, it is actually writing to the manufacturers, in this case use the FDA repositories or FDA databases. Because they frequently include a lot of the unpublished data, or EMEA in Europe. We frequently write to investigators in the field and ask them whether they're aware of other studies. So, and then we document it according to that, and we document how many responses we get and things like that. So those are the three key strategies. People who have published in the field. Yes.
My question was the same.
Oh, okay.
Thank you.
Good. All right. So what is important in deciding when you decide about developing a guideline is obviously that you know what the scope of your guideline will be. For many instances in the ACIP world, I believe that the guidelines are initially fairly narrow, or you can make them fairly narrow. In other instances, the guideline can become very broad. And as my colleague Sue Hill from WHO actually said, small is beautiful. And in particular in this context, so start with a manageable number of questions with a manageable task. That is very important in order to not get frustrated, but also it helps you to really focus in. You need to consider who is the target user of the guideline, who it applies to, what is covered. So for instance, are you speaking about diagnosis and treatment, or are you only speaking about treatment or diagnosis? And the examples that I will be using are not necessarily immunization examples, and I guess there's a good reason for that. So keep it small, develop a number of key questions. We ideally start with less than 20, definitely less than 20, ideally even less than that. And that very much relates to what healthcare workers actually want. They don't see a guideline, or they don't want a guideline to be a textbook or a cookbook. They prefer seeing guidelines that actually answer their relevant questions in practice. They would like to know that the guideline is really evidence-based. They don't need to necessarily see all of the evidence in very complicated presentation formats. They frequently just are looking for a quick answer, frequently. Not always, obviously, and they require clear recommendations, and I will speak more about that later. Who should develop these guidelines? I guess you have your procedures and processes for that, but we reviewed this at a certain point, and there's really not a lot of good evidence out there. There was a systematic review that is relatively old, but it is pretty clear that the composition of guideline panels influences the recommendations. Therefore, you need balanced groups, obviously. You need good group leaders. This has always been important, so I have developed probably about 20 guidelines with WHO over the past 5 or 6 years, most of them as a chair of a guideline panel, or many of them as a chair of a guideline panel. And the leadership of the group is extremely important because of all the group dynamics and group processes. But more importantly, preparation of the exercise is critical. So when you get together with a group, obviously you need to have the questions defined, but the material needs to be presented in a way that you can actually quickly come to decisions rather than having long discussions. And I think we will learn over the day how this can be done. So you need the necessary technical skills, obviously information retrieval, systematic review expertise, health economics. You need people who have experience in group facilitation, project management, and obviously writing and editing. And you need to obviously include content experts. There's been lots of debate about that. Some groups have initially probably taken a too radical approach and given very little emphasis on experts or content experts after the first concerns about conflicts of interest came to play, and I think this is going way too far. You need content experts to formulate your questions appropriately. You need content experts actually to tell you where to find this additional evidence. So it is about defining the role of everybody involved in the guideline panel appropriately and ensuring that competing interests don't influence recommendations. And undoubtedly, you will have read a lot about this over the past 10 years or so. There's also a big report, once again, from the Institute of Medicine, the IOM report on conflicts of interest, which includes a large section on guideline development and provides good guidance. Groups should be manageable. We typically say not larger than 15 members, because otherwise it becomes difficult to get everybody involved. And those are the folks who should be involved. I briefly spoke about that, but by involving the relevant stakeholders, although you probably have, once again, your processes in place for whom to involve, but by involving relevant stakeholders, you create ownership in the recommendations, and that hopefully, at least that's what the sparse evidence indicates, helps with implementation and acceptance of the guidelines, of the recommendations. Once again, so implementation is one key issue. I just wanted to briefly go back to that particular issue in terms of who should be involved and the expertise needed in the group. Obviously, the medical content, I refer to that, but I wanted to emphasize the issue around values and preferences. This is really coming from the utility, from the quality of life literature, the understanding that not every outcome is equally important, and that the target population of your recommendation may actually have or assign different values and preference to certain outcomes. So risk aversion plays a big role. So individual values and preferences can be important when you formulate your recommendation. Coming back to that as well, but you need to consider that in your guideline development process. How are you going to deal with making a judgment about how important certain outcomes are and whether vaccines or other interventions are acceptable? And then once again, I mentioned the technical professionals, the epidemiologists, and this is just a lead into the next slide. You need people who can understand and prepare the evidence summaries that your guideline panel will actually need. And this is an example for why you need this expertise. I like using this example. It's from our earlier writings. So this is a clinical recommendation, very clinical. For those of you who are clinicians, it's perhaps a bit simpler, but when we started this work, we looked at various grading systems, different ways of assessing the quality of evidence, and used our own examples. I was doing a lot of work in the antithrombotic field at that time, and this is a very typical recommendation that you would find for patients with atrial fibrillation, so irregular heartbeat of the atrium in the heart, which basically puts patients at a high risk for a thromboembolic event, so blood clots that can then travel to various parts of the body, in particular the brain, causing stroke. And some of these patients are also affected by rheumatic mitral valve disease, so particular valve disease that perhaps even increases this risk further. Now, if you were a cardiologist or a primary care physician looking for guidance on what to do with these patients, so whether to prescribe them antithrombotic therapy, you might have looked at the very prominent guidelines in the field, such as those from the American Heart Association, and they would have told you this is evidence B and a class 1 recommendation. However, as a practitioner, you may not want to look at only one guideline. If you had looked at the American College of Chest Physicians guidelines, the group that I was working with at that time, they would have told you that it is A evidence and a Arabic 1 recommendation as opposed to class Roman 1 recommendation here. And if you were a practitioner in Europe or an international practitioner, and you would be aware of the Scottish Intercollegiate Guideline Network, which is a very prominent guideline developer, they would have told you it's a Roman 4 evidence C recommendation. Okay. As a practitioner, this is pretty much like standing in front of a traffic light. They all tell you something else on the traffic light that actually doesn't exactly tell you whether you should be doing something or not doing something. And coming back to that, the interesting thing here is not necessarily that these groups perhaps have had a different view on the evidence, but the interesting thing is obviously that they all use different systems, and you don't necessarily can take a message away here. The other interesting thing is that all of these 3 groups looked at exactly the same 5 randomized controlled trials. And those are 5 randomized controlled trials that do not include patients who have this comorbidity here. They all made judgments about how good this evidence or how well this evidence applies to patients with this particular condition. And for various reasons, they then said that they would either downgrade the evidence and perhaps not be as strong in terms of their recommendations. The real problem is that we have no idea of why they made these judgments and why they considered this A, B, or Roman 4. Because all of these systems at the time did not provide you with clear information for the judgments that lead to lowering your confidence that you should prescribe a particular therapy to these type of patients. There was simply a lack of transparency. There was a lack of a standardized framework. The AHA recommendations, for the most part, SIGN as well, just spoke about randomized controlled trials that were well done or not well done, and that there was some extrapolation needed. But there are many, many more issues. For instance, issues around imprecision, because despite the fact that there were 5 randomized controlled trials, there were only very few events. There were not more than 40 events, if I remember it correctly, otherwise it's close to that number, in over 5,000 patients. Anyways, so there was a lot of confusion, and this was one of the reasons why about 11 years ago, so Grade said that I'm one of the initiators. It's probably true, so I've been involved from the beginning. I'm also responsible for the name. Perhaps that's my biggest contribution. But anyway, well, I think there are others. But we came together about 11 years ago, and with the aim to develop a common and transparent system that would be sensible to assess the quality of the evidence or our confidence in estimates of effect, and then develop recommendations. And we did that by being aware of reports that were ongoing, reviews that were ongoing, in the meantime, over 100 systems that were out there to assess the quality of evidence and strength of recommendations. It's an international group from really around the world. We have now over 250 members. Anybody can become a member. What it means is signing up to a mailing list. We are not a formal organization, and we don't want to become a formal organization because it's worked so well in the way that we are currently handling it. We are meeting about 2 to 3 times a year. We've written a lot. There's just a series in the Journal of Clinical Epidemiology coming out. The first 10 papers on in this series have been published now or are in press, and there's another 10 papers that basically brings together the experience and describes the approach in detail. You have all of this in the handbook, in the profiler, in the electronic handbook that comes with the profiler. And that will be updated as these papers are updated. So it's an international group with input from various organizations. Actually, CDC was at the first meetings, or a member of CDC, Dr. Briss was at the first 4 or 5 meetings, and then Farouk became involved. So there was some, I think, a lot of input from public health groups right from the start, although it's frequently mistaken that we are focusing on clinical recommendations, which we are not. So it's been taken up by a number of groups, including now CDC ACIP that has adopted GRADE to its purposes. The World Health Organization was one of the first organizations to start using GRADE, and it's being increasingly implemented. But you see a lot of the professional organizations in the US, but also big national organizations such as SIGN now, the Scottish Intercollegiate Guideline Network, that is really very prominent, and the NICE in the UK. Okay, so this slide now is a complicated slide. It will tell you what you will know at the end of the day, hopefully. I hope we don't have to stop there, but it just lays out the process. It lays out the process and the relation between systematic reviews and guideline development as we see it. Now, obviously, a guideline should start with formulating questions that you would want to answer as part of your with a recommendation. This should involve a guideline panel from our point of view, from my point of view, or those who use the systematic review right from the start, because there are not the systematic reviewers necessarily, but members on the panel who can influence, who can provide this important information, what the key questions are. And the key questions we formulate in using the Pico concept. So who of you has heard of the Pico concept? Okay, that's almost everybody. Well, I would say 70% probably, closer. So the Pico concept defines the population, the intervention, the comparator, and the outcomes. And it's probably a complete way of formulating questions. It's not one single outcome. It is always many outcomes because there are always benefits and downsides. Groups or systematic reviewers need to make judgments about how important these outcomes are, because not every outcome that you can think of or that is reported in the literature is really important for decision making, and these judgments need to be made in order to reduce the workload and in order to make sensible, have the opportunity to have sensible discussions and not focus in on outcomes that are really not relevant, for instance. So there need to be judgments about the importance of an outcome. In this particular approach, once you've decided which outcomes are potentially important or critical to decision making, the literature search would be done, or you would use an existing systematic review, and under those circumstances you would look at these outcomes across studies that might be published. You would create a summary of that. We use summary of findings tables or these evidence profiles, evidence summaries that we will speak about today, that are also in the paper that Farouk actually led and published in Vaccine. One way of presenting information, evidence profiles for interventions that deal with immunization or vaccines. And we do this, we create these evidence profiles really in the context of making judgments about the underlying confidence in the estimates of effect. So we rate the quality of these outcomes in 4 categories. Once again, terminology is important, but it shouldn't be an enemy here of moving forward. We have chosen this terminology, but ACIP has decided to use a different terminology. The key is there are 4 categories, and the assessment in these categories, and that's the important part, is based on a framework that includes a set of criteria. We currently have 8 criteria that lead to assessing the confidence, that influence the assessment of the confidence in estimates of effect. The first is risk of bias, inconsistency, imprecision, publication bias, indirectness, sorry, I skipped over that, then whether there is a large effect, whether there's a dose response, and then issues around confounding. All of these 8 criteria I will go through in detail, and then you have a chance to look at the systematic review and do this assessment yourself. We assess the confidence in these estimates of effect using these 8 criteria, but at the end, when you are formulating your recommendation, it becomes pretty clear that your recommendation will rarely be based on one single outcome. The examples are really very rare. Usually, as I said, it's an evaluation of the benefits and the downsides, so that you need to bring together all of these outcomes that are critical and express how confident you really are that implementing this recommendation will do more benefit than harm. And once you've decided that particular outcomes are critical for decision making, those outcomes cannot be ignored. And therefore, in this approach, and we had a lot of debate about that, the overall confidence is expressed by the lowest quality of the critical outcomes. So, and that will become more clear. I will provide explanation for that as well. Okay, that is being fed back to the panel, so the systematic reviews and the evidence profiles are being brought back to the panel, and the panel then makes a decision about the recommendations. And in this great approach, there are 2 different recommendations, as there should be. There are recommendations either to do something or to stop doing something. They're either made, in other words, for or against an intervention, and there are 2 categories. In the ACIP approach, it would be category A and category B. We call it strong or conditional, also called weak. Once again, this is terminology that works for different audiences differently, and therefore there's probably the requirement for some flexibility. The key is there's either recommendations for or against, and they can be strong and weak. Only in very rare circumstances, we believe a guideline panel should not make any recommendation. Therefore, it's not even mentioned here. And there are 4 factors that influence the strength of a recommendation: the quality of evidence, the balance between benefits and harms, the values and preferences, and resource use. And that should end up by the panel making very clear recommendations that are formulated in certain ways. Also, there is guidance in the paper that Farouk actually authored, how that can be done. We provide this guidance here. So that's the overall process. And once again, I remind you to ask questions as they come up. All of this is based on the general principles of evidence-based healthcare decisions, where it is important to consider the state and circumstances of a recommendation. So what is the context? Are we dealing with a nationwide recommendation? Are we dealing with the circumstances of providing care for patients in tertiary or primary care hospitals? So those are the state and circumstances. The population values and preferences related to an intervention, and the research evidence. These 3 pillars need to be integrated, and that is being done by using expertise, obviously by using trained individuals. Now, I will focus on the research evidence on the confidence in estimates of effect as they relate to interventions on the next slides. The way that we look at it is that when you have a question, there is evidence. This evidence may be of extremely poor quality with very low confidence in estimates of effect, or it may be of high quality and where you are very confident about an effect. But the key here is that we need to distinguish between these different categories of evidence, obviously. And that means that we sometimes are more confident, as I said, and that is usually based on the fact that we have better research. Better research means that there's a hierarchy, and there are a number of these hierarchies out there. As I said, over 100 systems. This is a hierarchy, or the hierarchy from the forefathers of grading systems from the 1970s, and where randomized controlled trials were on top, cohort studies and case control studies were right below, then case reports and case series non-systematic observations came here, and expert opinion was at the very bottom. Now, there are a couple of things to say about that. Number one, expert opinion is not a form of evidence. We emphasize that all the time. It is not a form of evidence. It is an interpretation of evidence. And what was meant by these groups, by the forefathers of the evidence hierarchies, it's actually explained in their texts. It is expert opinion based on these non-systematic observations, right? It's non-systematic observations. That means that if you are working with experts and they provide you with their opinion, you should ask them actually for their evidence. And even if it's a narrative description of what they have seen in their practice, obviously it will be highly biased. But that is similar to just looking at case reports when they provide the narrative description. Can you trust them or not? Obviously that is expressed by the bias. But it's not expert opinion in itself that forms evidence. And there are other reasons for not including expert opinion here. I use this slide all the time. It's a quote by a very smart man. Everything should be made as simple as possible, but not simpler. And these evidence hierarchies are way too simplistic. I use the following example to make this clear. If you look back at if you think back at the evidence hierarchy, it becomes very clear that just categorizing studies by their intended design, RCTs or cohort studies, is too simplistic because there are a lot of factors that can actually influence estimates of effect, such as in observational studies, confounding effect modification and external validity, concealment of randomization, blinding, who is blinded in a double-blinded study, and the answer to that is nobody knows. If you know who is blinded in a double-blinded study, then you're probably wrong, because there were good studies actually looking at doing surveys and looking at textbooks. Everybody intends to say something different. Very interesting. P.J. Devereaux, 2001 in JAMA, actually. It's an old paper. People still use this terminology for some reason. Intention to treat analysis and its correct application, and then p-values and confidence intervals. So my question that I usually ask the audience is whether anybody would feel comfortable in coming up here and explaining this to the rest of the audience. And these are usually guideline developers, and there is a minority of hands going up. It's usually less than 5%. Which pretty much tells you that this is not bad. It just tells you that you need expertise in order to assess these different forms of evidence, right? You need different expertise for the different tasks on a guideline panel, but certainly somebody needs to know about that. And it also tells you that these evidence hierarchies are too simplistic because a lot of things can go wrong. There's another reason for why we don't believe in these simple evidence hierarchies. Who of you has seen this particular paper? Okay, only half of you. Assuming that everybody participates. Who has not seen the paper? There should be the other half. Okay, you're all participating. That's good. This is a paper actually published in the BMJ 2003, a systematic review of randomized controlled trials looking at whether parachutes prevent death when you jump from an airplane. So obviously they didn't find any randomized controlled trials. Yes, that was actually intended to be a fun contribution to the literature, which is interpreted by critics of evidence-based medicine as a real article. This was published in the BMJ Christmas edition, which is usually the edition when they make fun of everybody. And these authors made fun of themselves. You should look at the declaration of interest. Anyway, it's a really fun paper to read. The point here is that under certain circumstances, or under many circumstances, you may not need randomized controlled trials. But the question is why, right? when do we not need randomized controlled trials? It's not enough to just say we can't do randomized controlled trials. Interestingly enough, and I'd be interested in your opinion, there are no good frameworks that really tell us. There's a lot of information out there in terms of how to do studies well, observational studies well. But there's very little information out there that tells us what framework can we work through in terms of assessing our confidence that the observational studies provide sufficient evidence. And that's what we've been trying to do. So to provide a framework of saying, okay, we are confident that there is an effect. So in this case, for instance, we would have said that you can look at the evidence. And this evidence is better than many of the healthcare evidence that we have when we address healthcare questions. The US Parachute Association registers every jump from an airplane. In 2007, there were 821 injuries and 18 deaths out of 2.2 million jumps. That is actually based on a registry, as I said. We can assess the quality of the evidence, but the key point here is, even if there is bias involved, the relative estimate of effect is a 99.9% relative risk reduction efficacy. My challenge is always, can you think of healthcare interventions that are equally effective? And you will come up with very, very few examples. I'd be interested in hearing some. So the point here is large effects make us more confident in that an effect truly exists, and it makes us more confident that we don't need randomized controlled trials, and it makes us confident that an intervention possibly comes with benefit or downsides. And it is not usually, in this case, many people start by saying it's the mechanics, it's Newton and Newton who has taught us that parachutes work. Actually, the initial parachutes, here are some designs by Da Vinci actually, they didn't work, right? And the first animals that used parachutes also didn't survive. So the point is, this is way too simplistic. We need expert opinion to really interpret evidence. Expert opinion is not a form of evidence, and it provides the rationale for why we make so much effort in assessing the quality of evidence, because we can't just take the study design. Now, why do we bother then? People draw conclusions about our messages about the quality of evidence and strength of recommendation. Systematic and explicit approaches can actually help to protect against errors, resolve disagreements by ensuring transparency, facilitate critical appraisal, and communicate information. We assess the quality of evidence, but we also develop recommendations, and recommendations are judgments. They will always be judgments. Our task is to make the judgments transparent. This will never be mathematical science. This will never be a 1 + 1 = 2 approach. But we can make the approach at least semi-quantitative, and perhaps with time even more quantitative by using appropriate decision modeling. But right now, it's really judgments, and we need to make the judgments transparent. When we move to recommendations, we consider our confidence in the estimates of effect that influence the trade-off between the benefits and harms, and we need to consider the values and preferences, so how important certain outcomes are, and the resources that are actually possibly required to implement the recommendation. Once again, the judgments need to be based on the best available evidence, but you need to make them transparent. So that guidelines then are a way of answering questions about clinical communication, organizational or policy interventions, and we produce these guidelines or recommendations with the help to improve healthcare or health policy in general. Because guidelines are a way to answer questions by considering all these factors, we find it is helpful to structure guidelines around clinical questions or healthcare questions in general. I will speak briefly about questions that is relevant for our exercises. We separate our two different types of questions. We separate background questions from foreground questions. The background questions are usually related to definitions or mechanisms. So, for instance, what is H5N1 influenza? What is the mechanism of action of oseltamivir therapy? Foreground questions deal with questions around efficacy, and weighing the benefits and downsides, such as in patients with H5N1 influenza, does oseltamivir improve survival, as opposed to the background questions that you see above. And these are framed in the Pico context. So as I said, or as I asked you, there's still a relatively large proportion in the room who hasn't heard about the Pico framework. So we define the population, the intervention, the comparison, and the outcomes. And I'll give you a quick case example. This is from a WHO guideline that we developed a few years ago. I use this example all the time because it was one of the first really well done guidelines, I believe. Leave the recommendations, without talking about the recommendations, first of the really well done guidelines using this approach and making the decisions transparent in a way that we would like to see them. So this is a case scenario of a 13-year-old girl that lived in rural Indonesia and presented with flu symptoms and developed severe respiratory distress over the course of the last 2 days. She required intubation. History revealed that she shared her living quarters with her parents and her 3 siblings. And at night, the family's chicken stock actually shared this room, and several chicken had died unexpectedly just a few days before the girl fell actually sick. So you will be very familiar with these type of reports. I was not that familiar with these type of reports because I'm an internist and don't deal with these surprising new diseases all the time. And not an infectious disease specialist. Anyway, these were the case scenarios that were posed to, I'm sure, CDC and WHO at the time, and there was a request for developing quick advice. So we were recruited to help with the development of guidelines, and obviously the panel developed a number of background and foreground questions, but one of the interventions that we were asked to address was obviously antivirals. I'm not sure whether it's me, the battery, or, it's me. Sorry. I have to hold it down here. So that a typical question based on this scenario would have been, in patients with avian flu or influenza H5N1, does oseltamivir compared to no pharmacological intervention reduce mortality, reduce hospitalizations? What does it do to resource use? What are the adverse outcomes to be expected? And what happens to antimicrobial resistance? Those were the type of outcomes that were considered critical in answering these type of questions. And you quickly see in this Pico framework, you define the population as specific as you can. Sometimes you start broader in order to make the workload appropriate, and we can talk more about how to narrow down. The intervention is clearly defined. The comparison, there's always a comparator, is clearly defined as maybe another therapy, or it may be doing nothing, or usual care. And then the outcomes are defined in terms of how important they are for decision making. And that, just to emphasize this point, reminds me that really every decision comes with desirable and undesirable consequences. That's why we place so much emphasis on all of the outcomes. The developing recommendations must actually include the consideration of the desirable and undesirable outcomes. They should be patient or population important. Lab values are frequently not patient or population important unless they have been established as good surrogates for patient or population important outcomes. And when we choose outcomes, we separate, as I said, the desirable outcomes from the undesirable outcomes. And if you just think of examples, lowering mortality, reducing hospital stays, as I said, duration of disease, reduced resource expenditure are all desirable outcomes. And the opposite is here, adverse reactions, typically a development of resistance or the cost of treatment, allergic reactions. If you think of immunizations, are important undesirable outcomes. You need to choose them appropriately. The approach that we have taken frequently, and that works very well in these guideline experiences that we had, is to ask the guideline panel to consider all of the outcomes that are important and then do a ranking exercise. So when we do these ranking exercises, we ask individuals to consider the relative importance of the outcomes that they have developed, that they have come up with, through Delphi exercises, through reviewing the literature, we then ask them to really consider which ones are important for decision making when you balance them. And it becomes frequently clear that the relative importance of these outcomes vary across a population or within a population. And under those circumstances, this is important information because it frequently makes you less confident that you can just offer a general recommendation or statement. So we use 9-point scales to do that. And the way that we operate this, and as we will do it in the exercise today, once again, as one approach to doing this, is by defining outcomes that are rated as 7 to 9 as critical outcomes. So those are really critical for decision making. You need information. You need to balance these outcomes in order to make a recommendation. Then outcomes that are rated as important but not critical, they are usually included in the evidence profile because you need this information or are interested in this information in order to make this overall judgment, but they don't influence the overall quality of the evidence. And then those of low importance. So rating from 1 to 9, and when they are considered critical, then you should really be evaluating the literature. So this is one example. So if you were to think of the question that I just posed, a panel might have rated mortality as a critical outcome for decision-making, hospital admissions, and pneumonia as well as a respiratory tract complication. They might have evaluated neurological complications as important but not critical for decision-making, and nausea as a side effect in patients who are critically ill as of low importance. Okay. So the questions that I perhaps have for you, and perhaps you have quick thoughts on that, or you tell me whether you would want to discuss it. What if what is important is actually not measured? What if what is measured is not important? And I've made several statements in that regard. And how do we make sure we've really covered all the important outcomes? These are usually questions that I experience. Is any of those three questions interesting to you in terms of further discussion? And I just take a quick view. Do you have any thoughts on that? Yes, Larry, please.
Yeah, the one that is important is number 3. After talking with Philippe, when Jean and I did a few days ago, making the important outcomes and then having a committee not agree with your outcomes at a less than optimal time. So how do you recommend that the outcomes be determined, I guess, with all the people that would be involved in a group to make those recommendations? Okay,
so I will speak about what we know from other guideline groups and what we've done with the guideline groups that we work with. In our view, it's key, if you think back to this more complicated scheme where we separated systematic reviews and guidelines, in our view, it's critical to get the panel involved right from the start, at the systematic review stage. And the way that we do this frequently is the following. We use a Delphi approach that can be done electronically with many of the guideline panels. It avoids having to meet in person. So we start by, as a first step, you can do two things. One is you provide an already existing list of outcomes that you know of because you are aware of the literature, and circulate this to all of your panel members, asking them to look at this list and add to the list what they believe are other outcomes that are important for answering the question at hand. So where you define the population, the intervention, and the comparator. That's usually something that the guideline panel does. But you ask them for additional outcomes, either by already providing them some or by just asking them in general as a second approach what outcomes they think are important. We go through a second step that can all be done electronically. We use SurveyMonkey or other survey tools on the internet. We then provide them with a list of the outcomes after having categorized them, because frequently they just use different words for the same concept. And then ask them, is this list now complete? So the second step, all of this can be done in a relatively short time frame. Is this list complete? This is your chance. If you don't raise your voice now, we are not going back to this. You had your chance to participate. We use all the diplomatic and nice language that you should be using. I say it very simplistically here. And the third step then is to perform the ranking. The ranking is where we everybody has agreed on what outcomes should be looked at, potentially, what might be relevant for decision making. We then send it out and do an anonymous, and that's important, an anonymous ranking where everybody on the guideline panel provides the ranking from 1 to 9 for each of the outcomes. Many groups do it this way. It's probably it's probably self-evident, but in terms of using these Delphi processes, works extremely well because you avoid the discussions that Larry, you just referred to when it comes to the first guideline meeting. You get agreement, and then the other advantage of using a numerical scale here is that your experts usually like numbers. When you can bring them back and say, but the mean was 7.8 or the mean was 2.3 for that particular, or the median for that particular outcome, and that is why. That provides frequently the answer that is is sufficient enough, because they like to look at numbers. But it really helps you to understand the distribution. It provides a lot of information, and it usually brings down. One of the other important things is that we try to limit it to a certain number of outcomes. We inform people that they really need to use these ranking very wisely by in a way that you reduce it to a number of outcomes that actually can be digested at the end. Yes, Jean.
So just to follow up, and I think especially for benefit of the ACIP work group leads who are here today, most of the people here are connected with ACIP work groups, and then there's other people, but because Larry and Farouk and I had a detailed conversation with Phil, what we got from that, which I think Larry was alluding to, but I just want to clarify, was that when SAGE working groups prepared draft recommendations and graded the evidence, they did not, it wasn't until they presented to the full SAGE that the SAGE saw the questions that the working groups were asking. And so now, and I know you know this because you're working closely with Phil, they recognized that they should the working group should develop its series of questions, but then run them by the voting panel, which in our case is the ACIP, before going to all the work of grading the evidence to make sure that all the bases have been covered. So this was new information for us just this week, and we'll be following up with our work group members. But so just to clarify that internally the ACIP work group would develop the series of questions that they think appropriate, but then we would circulate it through the methods that you're recommending it to the full ACIP before they really dig into grading all the evidence, right?
Yeah, I think this vetting of the outcomes is extremely important. It's the of the four components of the question formulation, the outcomes are usually the contentious items. So the consensus is required early on. It really is required early on. And I mean the other reason, if you look at systematic reviews, the other reason is that it reduces it's common sense, but it reduces the workload dramatically. Because if you look at systematic reviews, there are systematic reviews with over 30 outcomes. They could have probably provided information on the 5 most important outcomes and be as informative and perhaps less confusing. So it reduces the workload. It just makes some information more presentable and avoids some multiple testing issues and things like that. Yes, Larry.
And then one other follow-up. Once you have the outcomes generated and gone through the process that we just discussed, some of those should be graded and others probably shouldn't. Either primary and secondary or major, minor, however you want to determine it.
Yeah.
And for vaccines, it's a lot easier than it is for NICU infections or some of the things that our other colleagues are working on. So at what point and how do you determine which ones are the major ones that should be graded? Not that the minor ones aren't important, because recommendations will be made on those, but how do you determine and when do you determine which ones grades applied to and which ones grade is not applied to but still are recommended? Because like you said, you don't want to have a whole lot because the work is immense and the understanding would be very difficult.
Oh, okay, so Larry, if I understand the question correctly, what recommendations we really need systematic reviews for, and when can you use common sense in a way, or not go through the full exercise. I refer you to the second paper in this JCE series speaks about it in great detail, and we have a lot of examples. But it really comes down to things that are where you would think that the expenditure of a systematic review is a waste of resources. Quick examples are, somebody bleeding, you stop the bleeding, right? You may do a systematic review on what methods are best to stop a bleeding when you have a trauma victim, but you may not do a systematic review and provide a graded recommendation for that you should first look at methods of stopping the bleeding. To give very simple examples. Recommendations for a physical examination when somebody presents with shortness of breath. These type of recommendations probably don't lend themselves necessarily to full-fledged graded recommendations, but you may want to look at what first examinations are appropriate. So we provide a lot of guidance, and I think it really comes down to defining the questions where there is perhaps greatest controversy, where you expect to be put in a position to provide a rationale for your recommendations. That may be every time, but in some guideline panels will not be every time. So some of the interventions will be much more accepted than others. So these are the kind of criteria that you would use, primarily new interventions, new vaccines probably. Those are the other decision criteria, and anything that you feel is a motherhood statement at the end, whether it's graded or not, probably doesn't require a grading. So if it's clear information, then don't do the exercise of doing a systematic review. Yes, John.
One more clarification, I think, in terms of vetting. Before ACIP, the work groups are formed, and they will contain a number of interested parties from liaison organizations. And that would be the group that is the panel that generates the initial questions and so on. And it sounds like we're suggesting that once we get the list of questions, the outcomes, that gets vetted before ACIP as a group that's going to be looking and voting on this. And just for clarity, should we consider also allowing the liaison organizations at least to look at that, or should we just suffice it to say that if they're interested, they should be part of that working group? I just want to make sure that again, we've heard of situations where you get all this work done, and it's like, oh, you were asking the wrong questions. Yeah. And so I don't want to make too much work and vet it by too many parties. Yeah. And so if we aim primarily at the work group, do we think that probably suffices in including our liaison organizations, who are ultimately the consumers of the recommendation?
Yes.
And many of the liaisons on the work groups are from these organizations that have a vetted interest in a specific vaccine. Like an adolescent vaccine, we'll have representation from all the professional groups that deal with adolescents. So there is, as John said, good composition, but there are others that may need to be included. Yeah,
so we have a little bit of experience with that, not perhaps the amount of experience that one would like to see, and we haven't written up carefully. But so I would have thought that if you look at how other organizations are doing this, it's always good to have a consultation process in the beginning. If you believe that the representation on the panel is perhaps not appropriate to really get buy-in at the end, and the consultation process would involve, these are the questions that we are going to ask. I would not involve the general questions that we are going to ask. I would not involve these organizations in the outcome definition. I think that becomes way too complicated. The other important aspect that we have found is frequently overlooked is that the representatives on the ACIP panel actually vet this with their organizations, because if they, despite the fact that they represent the organization, it may be a very individualistic view. And there a mechanism in place that they actually feed this back and get the consultation from the organization that they represent is critical. Not for the outcome selection, but just for the question formulation, because as you said, you don't want to address the wrong questions. And so that you just re-emphasize, and it's probably done appropriately, re-emphasize that they really represent an organization. And that's what the big organization, other big organizations are doing, that they are not there as an individual, but that they go back and get feedback from their organization in that case. That's what I would have said. If there are important organizations that are not represented, I would specifically ask them to provide input. So NICE has a lot of experience. Yes. And the public. I am, before we perhaps go to the next question, the public representation, the new IOM standards for developing trustworthy guidelines make very strong statements about the involvement of public and patient representatives. It's a very challenging area. We don't really know how to do it very well, but it's being pushed very, very strongly. What is the public? No, I know that's that's where the guidance probably lacks details because you can often go in the wrong direction. One of the ways of doing it is of thinking of surveys, or I think another way of dealing with it is to look at if existing in the immunization field. I'm not sure. Looking at values and preference literature and say that this is how you consider them public views. Yes, there was another question.
Well, this is really more a comment on I think what we're going to be struggling with for ACIP and which ones to use to grade on and which not. I mean, it seems to me for any recommendation we consider the scientific evidence. So why not put it into a grade format? I mean, if it's a staffing issue, then that's, you know, another point, but I think which it may be. But I think ideally we would want to do it for everything. I mean, the ones that end up being, you know, for HIV-infected kids and some of these ones where there's not so much data, it's good to be explicit and that end up not being strong recommendations. And that's probably the way they should be. So, I mean, I think that's going to be a challenge going forward, deciding how we approach.
Yeah, to give a specific example, for the HPV vaccine for boys recommendations, you know, the main recommendation is should boys be vaccinated.
Yeah.
Then another recommendation might be catch-up vaccination.
Yeah.
So should we grade both, or is grading the main one okay?
Yeah. Yeah, so to have a specific example, I agree with the statement that if you have a summary of the evidence, then I think it makes perfect sense, even by describing that you perhaps didn't go through some of the steps that would be involved. It makes perfect sense to transparently describe how confident you are in the estimates of effect for the various populations. So under those circumstances, if there is extrapolation or issues around directness by moving to catch-up vaccinations or to different gender to boys, if there's no direct evidence, describe that the evidence is indirect, and this system would allow you to say that we lower our confidence in the estimates of effect. We lower our confidence because of the issue that we perhaps haven't examined this particular population. But the evidence summary would still help you to make this judgment. You would have the evidence summary for one population, and then you would describe how you move to another population by saying that there are issues, concerns about the directness or the applicability of the evidence. So under those circumstances, I would agree with you. Once you have a summary, you may grade it with considering these particular issues. But my understanding was more when you have to decide on where you go and do a systematic review or look for the systematic review, that there are maybe questions where you don't want to do that. Or there are questions where you don't want to do that. Yes, please.
Specific vaccine discussion, but since it was brought up about HPV, in fact, it's the opposite. The population for which we have data is the catch-up population because the trials were done in the catch-up population. Okay? So I just want to point that out. I mean, the issue about the systematic review, by the way, for HPV, we're not planning on doing a systematic review in a sense because there's very few trials. We know all of the data. The issue really is not the systematic review. The issue is, are we going to apply grade in terms of grading the evidence for a routine and a catch-up? But I just wanted to point out to Farouk that actually the routine recommendation for which we are applying grade is not the age group in which the randomized trials were conducted.
Mm-hmm.
So what would you say about that?
Oh, well, it's not a problem because it asks you to make a judgment about how confident you are that you can extrapolate the data from the randomized trials to the population that you are interested in. And there are various ways of looking at this. Is there evidence that says that there is an interaction? It may be indirect evidence from other vaccines. It may be indirect evidence from observational studies. So once you think that there is an interaction, in other words, that the relative estimates of effect are different in your target population from the population involved in the trials, you may say that we lower our confidence and downgrade the estimate, the quality because of what I just said. In terms of, you said that you know all the data, that puts you in a very good position to actually perform a grading. Because if you have all the data on a question, then you might as well do your meta-analysis and go through the sequential steps of assessing your confidence that whatever this meta-analysis shows or what the summary estimate shows is correct or is high or low. Okay, yes, two more questions, and then...
Right. I guess I would be interested in any other comments you have about the first bullet. And I think maybe you addressed some of them just now.
Okay, so our approach here would be, if a guideline panel decides that there's an outcome that is critical or important for decision making, it should be listed in the evidence summary, and it should be provided. It should be said that there was no study, no RCT, or whatever it is that addressed that particular outcome. It is the issue around transparency. It is conform with what the big organizations are asking for. It's just providing the information that nothing was found for a particular outcome.
I haven't read all the details of the notes yet, so maybe it's in here. But, meta-analyses sort of group all these studies together, many of which may have lots of problems.
Yeah. Okay, we'll get to some of that. But, yeah, good discussion. Okay, let me move on. We have another 15 minutes before the break. I will try to be on time. So, I've talked about the outcomes, desirable and undesirable outcomes, and I've emphasized that every decision comes with desirable and undesirable consequences. And I've also mentioned before that when you develop recommendations, it must include a consideration of all the desirable and undesirable outcomes in terms of the quality of evidence. So you can't necessarily ignore outcomes in terms of quality once they've been defined as critical just because you don't like the quality rating that you came up with. In grade, I emphasized that before, we separate these two issues, 4 categories of quality of evidence. In the ACIP, it's 1, 2, 3, 4, right? We use we've used symbols, 4 plus 3 plus 2 plus 1 plus, or terminologies such as high, moderate, low, and very low. The terminology, once again, really depends on your target audience, I believe, and nobody knows how to do this best. There is really just not a lot of evidence. But when we do this, we look at the methodological quality of the evidence, in other words, at the likelihood of bias. But we are not talking about the bias in individual studies or just the risk of bias in the study execution and design, but we are talking about bias as it relates to your question and the information that you have at hand and how this information that you have at hand, the evidence that you have at hand really informs your question. So in other words, it includes issues such as directness or transferability, generalizability of the evidence, as well as imprecision and things like that. publication bias, for instance. So it's more than just the risk of bias in these studies, how they were executed and designed. And we do this by outcome and across outcomes. You see there's a lot of repetition, but much of this is relatively complex, so the repetition will hopefully help. And the recommendations are, I've mentioned that before as well, 2 grades, conditional or strong, category A and B, category B and A, in the ACIP terminology for and against, based on the 4 factors that I've described. So what do we mean by quality of evidence? So in the context of making recommendation, the quality of evidence reflects the extent of our confidence or the degree of our confidence that the estimate of an effect are adequate to support a particular decision or recommendation. And I show this slide all the time. It brings the point home that I was trying to make. This is 2 meteorologists sitting in an office, one saying to another, I figure there's a 40% chance of showers and a 10% chance we know what we are talking about. It is a very critical statement because there are 2 things in here. One is there's a point estimate of effect, right? 40% chance of showers. This may actually come with a very narrow confidence interval around it, from 35 to 45%, based on the models that they've developed and that they are using. Regardless, the confidence in this estimate and the confidence even in the confidence interval around this estimate may be very low. These may be 2 meteorologists sitting in the US and they apply models that were developed in Australia, right? So that their models may be significantly biased, and that lowers your confidence in any estimate of effect. Whether or not they had run the simulations 100 times, and the point estimates are the confidence intervals around the point estimates are very tight. So what we are dealing with is the likelihood of an outcome and our confidence in an outcome. It's different from confidence intervals around point estimates. We had a better term, more terms, that would be great. Because, once again, your confidence intervals are determined by the estimates of effect across various studies, but all of these studies may be biased. They may be all biased in the same direction, right? They may provide you with very tight confidence intervals, but they may be all totally wrong or completely right. Okay, so what determines quality? I mentioned that before. One of the points that we always make is randomization should really be considered the best method to protect against bias and confounding, and therefore a body of evidence from randomized controlled trials starts as 4+, or high quality, and observational studies start as 2+. We could have said right from the start, and we had a lot of discussion about this, everything starts somewhere in the middle and randomization moves it up. That would have been another approach to do that. But the point is that in particular randomized controlled trials frequently can be downgraded for these 5 factors that I will now go through in detail, and in particular observational studies can be upgraded for these 3 factors. One of the questions that came up, and I address it here right now, is whether randomized controlled trials, once they have been downgraded, so randomized controlled trials, you lower your confidence in the estimate of effect because of one of these 5 factors, can then be upgraded again. So an example would be a body of evidence from randomized trials. So can it happen? The answer is yes. Do we have a lot of examples? The answer is no. But theoretically, it's certainly possible. Consider a body of evidence of randomized controlled trials that have problems with randomization. In other words, the investigators all believed that they did randomized trials, but randomization went wrong. And for instance, they used quasi-randomization methods such as clinic visits on different days a week, or they used medical record numbers or date of birth or things like that, where there's concern about whether it's appropriate randomization. So a body of evidence such as that may be downgraded, obviously. But what it does is it really puts the randomized controlled trial at the level of a cohort study, of an observational study, all right? So under those circumstances, it would be irrational to say that they couldn't be upgraded if very large effects would be observed, for instance, because they are nothing else but an observational study once they have been downgraded for issues around randomization. There will obviously be a threshold for when you say the risk of bias is too large, the limitations in the design and execution is too large for upgrading again. Okay, so these 8 factors. We express this in these evidence profiles. I'll show you this quickly. This is very similar to what you will be producing and what is in Farouk's paper. So we break out the evidence profiles into information about the various outcomes. This is a simple example of using antibiotics for otitis media, but a guideline panel might have determined that important outcomes or critical outcomes are what is happening in terms of pain early on and later, what is happening in terms of, how is the outcome hearing or hearing loss affected at various time points, and what are the side effects such as vomiting, diarrhea, and rash, in particular in children. So an assessment of the quality would include how many studies there are, what is the underlying study design, are there issues around risk of bias or limitations in the study design and execution, is there inconsistency of the estimates, indirectness, imprecision, and other considerations that is then provided together with estimates of effect that are here on the other side, where we say how many patients were enrolled in these individual studies, how many events were in the studies, in both the intervention as well as the control groups, what is the relative estimate of effect, which may be your relative, your vaccine efficacy, and what are the potential absolute estimates of effect. In particular, in the vaccine field, you may actually base this on larger denominators than 1,000. What is the overall quality of the evidence or confidence in the evidence, and how important was the outcome actually? We separate that from the strength of recommendation. The strength of recommendation reflects the extent to which we can, across the range of patients for whom the recommendations are intended, be confident that desirable effects of a management strategy outweigh the undesirable effects. Strong or conditional, category A or category B. And what are the implications of such recommendations if you think of that for the patients or the population? It would mean that most people, if you have a strong recommendation in this situation, would want the recommended course of action, and only a small proportion would not. So that's an interpretation aid for the population. For clinicians, it means most patients should receive their recommended course of action. Usually you don't need to spend a lot of time on the discussion, because it looks like the recommended vaccine is clearly doing more benefit than harm. For policymakers, this recommendation can be adapted as a policy in most situations. When you have category B or conditional recommendations, as it is defined in the paper, in the ACIP paper, it's for individual decisions. I mean, every decision at the end is individual, but what is meant here is that you require much more interaction. Obviously, for patients, it would mean that the majority of people in this situation still would want the recommended course of action, such as either receiving the vaccine or not, but many would not. And there may be good reasons. You know, they may have had an allergic reaction. They may be not completely convinced that the evidence that is obtained in one patient group really should be transferred to a different patient group once you explain it to them, and you would have lowered your confidence and maybe made a weak or a conditional recommendation. For clinicians, it means they need to be more prepared to help patients make this decision, such as in the example that we just described, that should be consistent with their values and preferences. And for policymakers, it means that there's a need for substantial debate. In terms of the factors that determine the strength, I've mentioned these 4 factors repeatedly. This is a bit more explanation. So when you have the higher the quality of evidence, the more likely you are to make a strong recommendation that is clear. The larger the benefits, or the more clear the benefit downside balance is, the more likely you are to make a strong recommendation. Values and preference, the greater the confidence in the underlying values and preferences. So in other words, if a panel is very sure that they know what the underlying values and preferences are, they are more likely to make a strong recommendation, or if there is very little variation in these values and preferences. So there are two factors that can influence the strength. You know that there's lots of variation. You shouldn't make blanket statements and very strong recommendations for everyone. In the vaccine field, probably less frequently the case, although I don't know that field very well. But anyway, so two factors that move a strong recommendation to a weak recommendation on the basis of values and preferences. And resources, that's pretty clear. If there's lots of resources expended for a relatively small benefit, you're more likely to make a weak recommendation. So in terms of the ACIP principles, I think everything that we spoke about really applies. There is, when the working group put the paper together in terms of grading the evidence and recommendations, there was a request for a focus on transparency that I think with this approach you can really achieve. It is clear that the use of evidence comes with evidence of varying strength, and the considerations of both individual and community health need to be are of importance when you make recommendations. It started out by adopting or with an adaptation of an existing evidence-based system. In this case, it ended up being great. And it was also clear that there's a need for continuous improvement of the process, and this is the reminder for me as we go to the break. I have never been on time as much as today. It's 10:30. As we go to the break, there is really ongoing work required for a lot of the factors that I mentioned, in particular when you go from evidence to recommendations. And the guideline community is trying to address guideline methods community is trying to address a lot of these issues. I think we've made a lot of progress in terms of assessing the quality of evidence, the value and preference, and the multi-criteria decision-making to moving to recommendations. It really is research that needs to be done. There will be changes. It would be wrong to say that this science all of a sudden has to stop, or we know everything when the rest of science is actually moving ahead. So there will be developments. The way that this working group actually works is that we consider the developments. In fact, we're just rolling out, we're 6 months into, I should say, a very large, about $5 million funded study in the EU, European Union, where we look at what various stakeholders who deal with guidelines and are consumers of guidelines would like to see recommendations presented, how they would like to be involved, for instance, how policymakers would like to be involved, what they believe are the important decision criteria. So this is a 5-year project. We're going to learn a lot. There are similar projects funded by other funding agencies, obviously, but I just thought to mention this. So this is, there will be changes. Yes?
Concerning the issue on values and preferences, how do you propose gathering that and presenting that information?
Yeah, okay. In terms of presenting it, we'll speak a little bit about it later on, but obtaining it. So ideal approach would be that we would support our values and preference statements and our assumptions by, once again, good literature reviews of what the underlying values and preferences are. Once again, I don't know the field of vaccination that well. I'm not sure what is out there, but for many other areas, there is a lot of information. In the cardiovascular literature, in the respiratory literature, there is information that we can actually use. So that would be the starting point, to say, do we have information about how people value exacerbations in comparison to a hospitalization and so on. Ideally, we would have a generic health-related quality of life tool, and we would have a comprehensive system that is better than QALYs that would help us with making these decisions. We don't have it. So, but we start looking for that, and we try to include this information and see at least whether there's lots of variation for a certain outcome, and then describe it transparently. So if not, so just then, and then I stop. If not, until now, we have used the implicit values of the guideline panels, right? That's what we've done. We have not been explicit in terms of describing what values and preferences they had in their mind when they made a recommendation. So if not, then the minimum, I think, is to describe the values and preferences that the guideline panel placed on the various outcomes, saying high value on mortality reduction, low value on temporary rubor of the injection side.
But it's not, so it is, what I wanted to, so that's very helpful, but I wanted to clarify, it's the value of the outcome, like we value preventing pneumonia. It's not a question about what the panel or what the literature says about the value of the intervention in preventing that.
Right.
It's
so
the value of the outcome itself.
Right.
Okay.
So this is the utility type of
okay.
definition
Okay.
of values and
Okay.
preferences.
I have another question on a previous summary slide that you showed that was, I think, Farouk's slide showing the summary of the evidence. Could you go back to that? Because I think this applies to a lot of vaccines. So
This
you
one?
have,
Yeah.
you have there, 3 randomized trials, no serious, looking at adverse outcomes. I think that says, okay, no, down below, 5, vomiting, diarrhea, rash. Well, in many situations, let's say there's 5 randomized trials and 1 is very large and 3 are actually small because they were like a phase 2 trial or something. They're smaller trials, and of course they're not really large enough to find any adverse events, and so they're going to have nothing found, and so they're really limited because actually they don't have any power to find anything. And so the question is, how would you deal with that in terms of including that? Because they're non-contributory in a sense, but they're not really.
Well, they are contributory because they don't show any events.
But we wouldn't expect them to, is what I'm saying, because they're so small.
Yes, but so the approach that we're taking, and that most groups are taking, is to say we look at the totality of evidence. Even if there are 3 trials that are small, 20 patients each, they don't find any events. The 3 trials contribute 60 patients who didn't have an event. That needs to be combined with the trial that included 3,000 patients and had 4 events, right? The issue is you need to look at heterogeneity. That comes out in the heterogeneity rating. So are they totally off in terms of what they determine? Is the rate of side effects 50%, and even if they had only 20 patients not finding any, that would make you suspicious, right? But the point is, we look at the totality of evidence. Just the fact that a trial is large doesn't necessarily mean it's better. And so we should not necessarily make these judgments on the basis of size. So we consider everything. Once you've decided what your inclusion-exclusion criteria are, you can't exclude studies on the basis of showing no event or being small.
We could do that. We could exclude them.
You should not.
But you should not.
You should not. Your inclusion-exclusion, because that would be a selection that would likely lead to selection bias. So that's why your inclusion-exclusion criteria need to be determined a priori. But you will do an assessment of the risk of bias. You may be less confident. So I'll come to that as well.
That's not helpful.
In fact, sometimes the only way to detect signal is through the studies that perhaps you are less well aware of. Because there may be reasons for reporting, or there may be the only study to actually report on a certain outcome.